Welcome to Dental Symphony. In this video, we will explore dental bleaching from a clinical and biochemical perspective. The physiological color of teeth varies with age due to changes in tooth structure and composition. In children, teeth typically appear whiter because of a thicker enamel, which gives it a milkier, lighter appearance. In contrast, as individuals age, the teeth often appear more yellow or darker due to deposition of secondary dentine, which is naturally yellow and less translucent than enamel. Its increased thickness becomes more visible through the enamel, and this contributes to the darker tooth shade. Additionally, the enamel may wear down over time, termed as attrition, which further exposes the underlying dentine and accentuates the yellow hue seen in elderly individuals. Let's take a look at the physiology of tooth color to understand these differences better. In teeth, translucency plays a key role in how color is perceived. Enamel, as we know, is composed of highly organized hydroxyapatite crystals, which are arranged as enamel rods. Because enamel is semi-translucent, it allows light to pass through and reflect off the underlying dentine. In younger individuals, thicker and more intact enamel results in better light diffusion, making teeth appear brighter or whiter. Dentine, on the other hand, is made up of a mineralized collagen matrix with dentinal tubules, and it has a yellowish hue due to its organic content and low mineralization compared to enamel. Dentine scatters and absorbs light more than enamel does. As light penetrates the enamel and hits the dentine, it picks up the dentine's yellowish tone. In older adults, dentine becomes thicker due to continuous deposition of secondary dentine, which makes the teeth appear more dark or more yellow over time. Tooth discoloration is classified as extrinsic or intrinsic. Extrinsic stains are superficial stains present on the outer surface of teeth developed from local agents known as chromogens. Common causes of extrinsic discoloration are tea and tobacco stains, Naismith's membrane, which are seen as greenish discoloration in children, teeth discoloration caused by poor oral hygiene. Extrinsic stains are bound to the tooth by attractive forces such as van der Waals forces, thus they can be removed by scaling and polishing. On the other hand, intrinsic stains develop by incorporation of chromogenic material within the structure of the enamel and dentine, hence they are not easily removed by oral prophylaxis. Intrinsic stains can be caused by consumption of certain medications during the formative years of tooth development, like for example fluorosis, which occurs by excessive consumption of fluoridated water, and tetracycline stains because of the consumption of these antibiotics during the formative years of teeth. Another common cause of intrinsic staining of tooth is decomposition of pulpal tissue due to trauma, which leads to hemoglobin byproducts being accumulated as pulpal remnants, giving the characteristic pulpalish bluish appearance. Calcific metamorphosis, where there is rapid deposition of reparative dentine in response to trauma, causing partial or complete obliteration of the pulp canal and of the pulp chamber and root canal, leading to a yellow discoloration of the affected tooth. Certain filling materials such as amalgam can lead to leaching over long term, causing localized staining of teeth. Also, as already discussed, aging leads to generalized staining or change in color of teeth from white to yellowish, owing to the thinning or attrition of enamel, thickened in secondary dentine, which is more yellow and shows through the external surface. Talking about dental bleaching, bleaching is defined as the lightening of the color of the tooth through the application of a chemical agent to oxidize the organic pigmentation in the tooth. Let's break down the definition to understand the mechanism. So, bleaching occurs by using a chemical agent which causes the lightening of the tooth color by inducing a redox reaction, that is, by oxidizing the organic discolorant, which then appears light in color and doesn't stand out as a distraction. So, it does not remove the discolorant, but bleaching creates a camouflage, making the discolorant appearing light. Now, let's look at the underlying biochemical mechanism. The intrinsic stain molecules, these are large complex organic molecules, and they're attached via double bonds. These double bonds are the ones responsible for the darker appearance of the stain molecules. Once adequately applied, the bleaching agent reaches the stain sites within the enamel and dentine. The free radicals of bleaching agent interact with the organic molecules to attain stability. The bleaching agent opens the more highly pigmented carbon ring, which is responsible for giving the tooth a yellow color, and converts it to carbon chains. So when the carbon double bonds are converted to hydroxyl groups, the amount of light absorbed is reduced. Thus, the tooth appears light in color. If bleaching process is allowed to continue beyond this point, then the organic matrix of the tooth is broken down, which results in weakening of the tooth structure and postoperative sensitivity. So saturation point is that point at which only hydrophilic colorless tooth structure exists. Bleaching beyond this point results in the breakdown of the organic matrix, resulting in weakening of the enamel and surface porosities. Coming to bleaching agents, hydrogen peroxide is the most common bleaching agent. It is used at a 30 to 35% concentration as an in-office bleaching agent. It is activated by heat or light, like for example plasma arc diode laser, which releases free radicals. Hydrogen peroxide is applied to multiple sessions, 5 to 15 minutes per application, and it is usually indicated for generalized staining, severe fluorosis, or tetracycline discoloration. Carbamide peroxide is used for at-home bleaching method. It decomposes into 3.5% hydrogen peroxide and urea. 10 to 20% carbamide peroxide is used in custom trays for daily use, about 4 to 6 hours or overnight for 2 to 4 weeks. Sodium perborate is a mild oxidizer, therefore it is used for non-vital bleaching, that is for endodontically treated teeth. The walking bleach technique was introduced by Nutting and Poe, which combines sodium perborate with distilled water or 3% of hydrogen peroxide. This composition is placed in pulp chamber, access cavity is sealed temporarily and changed weekly until the desired shade is achieved. The following images demonstrate the in-office bleaching technique. So in the first stage, you take 35% of hydrogen peroxide in-office bleaching gel, which is mixed and applied in all the teeth to be bleached. After some time in place, bubbles appear in the gel, which result from the decomposition of the hydrogen peroxide. A suction tip is first used to remove the gel, and then the tooth surfaces are cleaned via water rinsing. This is the at-home bleaching method. So prior to bleaching, brush the teeth with a wet brush. Don't use a fluoride toothpaste as it may interfere with the bleaching process. Then place a small drop of gel onto the front compartment of the tray for the teeth undergoing bleaching. Ensure that the trays are not overfilled because this bleaching agent can irritate or burn the gums. Prior to bleaching, apply Vaseline gel on the soft tissues, that is your gums. Then after filling the tray with the bleaching agent, seat it over the teeth so that the gel spreads around the teeth. Wipe away the excess of gel in the mouth using a tissue, or you can use a dry soft brush. Avoid contact with the gums. After treatment, remove the tray, rinse tray and mouth with lukewarm water. Now you can brush the teeth with a wet brush and you can use toothpaste as well. Looking at the walking bleach technique, so prior to the treatment, take a radiograph to ensure the quality of the root filling. Apply the rubber dam. The restorative and the obturative material is removed until below gum margin. Then apply a layer of cement over the top of the obturative material. The bleaching agent, say sodium perborate mixed with 30% of hydrogen peroxide, it is made into a paste. Then it is loaded onto the pulp chamber of the tooth. Then you place a temporary restoration to cover the cavity. The patient is rescheduled approximately 1 month later and the procedure is repeated 2 to 3 times as the desired results are achieved. And lastly, some technical considerations during bleaching. So not every teeth can be bleached. There are certain contraindications such as active caries or defective restorations, cracks like microfractures or exposed dentine, pregnant or lactating patients, and if the patient has allergy to bleaching agents. Also, certain risks associated with dental bleaching are tooth sensitivity, which is quite common. Ensure that the bleaching agent is applied only till the saturation point and not beyond that. In case of tooth sensitivity, you can use desensitizing agents like potassium nitrate based toothpaste. And there have been certain cases reported of external root resorption, especially in context to the walking bleach technique. So therein you need to ensure that you place a GIC or a zinc phosphate barrier over the Gatapaka. So this was about bleaching. Thank you so much for watching this video, and do like, share, subscribe to our channel. Thank you so much.